Today our topic of discussion is tumors of nasopharynx. They are broadly categorized into benign and malignant, and in the benign our main focus is on the angiofibroma, and in malignant our main focus is on the carcinoma. Moving on to our first topic, which is the nasopharyngeal fibroma, which is also known as JNA, the juvenile nasopharyngeal angiofibroma. It is a rare tumor, but it is the commonest, which means that normally this occurs rarely, but whenever a benign tumor of nasopharynx occurs, most commonly it is JNA. Right? Its etiology is unknown. It occurs in the second decade of life. This is an important scenario point that 10 to 20 years is the age of this tumor, and it is thought to be testosterone dependent because some researchers have discovered that this particular tumor is having androgen receptors. This is the reason that they say that this is testosterone dependent or puberty linked, and more commonly it is seen in males. Its site of origin is to be remembered that it is arising from the posterior part of nasal cavity. Its spread is by three modes: either by following the routes of least resistance. Wherever this tumor sees that the resistance is less, it spreads to that particular area, and either by expanding and pushing the structures, and by infiltrating and destroying the bone. Right? Now remember the location, which is the posterior part of nasal cavity. If it will spread anteriorly, it will go into the nasal cavity, and posteriorly into the nasopharynx, and superiorly into the sphenoid sinus, and laterally you just have to little bit keep a focus that it goes into the pterygopalatine fossa. And in the pterygopalatine fossa, what it does, it destroys the posterior wall of maxillary sinus, and on X-ray or on CT or MRI, what we see is that the posterior wall of maxillary sinus is pushed anteriorly, and this gives a particular characteristic sign, which is Hallman's Miller sign. This is a thing that you have to remember, right? From where, after destroying the posterior wall, it goes into the pterygomaxillary fissure, and then into the infratemporal fossa, and then into the cheek, and if it goes into the inferior orbital fissure, it can go into the eyes and cause proptosis. So this is the spread of this particular tumor, and if it goes into the foramen rotundum, it can go into the cranial cavity. Right? And if it goes into the palatovaginal canal, it can remain hidden, and it is the cause of recurrence. But this spread is based on the location, and then you just have to visualize the anatomy, and then you have to make the relations. You just not need to cram, you just need to understand and visualize. Right? Moving on to this is the highlighted part, that large tumors may cross the midline, and they can cause the bilateral symptoms intracranial into the which fossa? Middle cranial fossa. For example, if it goes into the cranial cavity, so which fossa is affected? Middle cranial fossa. This is a pathology. This is not that much important. It is having two components, vascular and the stromal. 75% of the tumor show androgen receptors, as I've discussed earlier. And yes, this is an important aspect, that this tumor is 24 times more common in patients of adenomatous polyposis of the colon. So if a patient is having this disease in the scenario, and then he or she is having I would say that he is 10 to 20 years old, and recurrent epistaxis is occurring, or proptosis, or cheeks are bulging, then you will go with the diagnosis of nasopharyngeal fibroma. Moving on to the clinical features, which is very important. Extensions are important, and I have described it earlier, that anterior extension, nasal cavity, posterior into the nasopharynx, and affect the paranasal sinuses, laterally into the pterygopalatine fossa, from where it goes into the temporal and the infratemporal fossa, from where it can go into the orbit on the cheek, proptosis or the bulging of the cheek, and then to the cranial cavity via the middle cranial fossa, and also affect the anterior cranial fossa. This is something that you have learned earlier. Now the clinical features, as I've mentioned earlier, that it occurs in 10 to 20-year-old patients. Right? And this is a very important presentation, that recurrent epistaxis. One thing that you have to remember about this fibroma is that it is excessively bleeding. Right? If I just palpate it like this, it will begin to bleed. So you have to be very vigilant, and you have to be very conscious that you don't have to touch this particular tumor. That is why for diagnosis we never ever do the biopsy, right? Because it will lead to excessive bleeding and further complications. Right? This was a long discussion. So the age is 10 to 20 years. The nasal symptoms are the most common presentation is recurrent epistaxis, due to which the patient may be anemic, nasal discharge. Otologic signs, when the tumor is going to spread. It is going to block the eustachian tube, due to which the tympanic membrane will be retracted. The conducting hearing loss can occur. Otitis media with effusion or acute otitis media, chronic otitis media, anything can occur. Why? Because of obstruction of eustachian tube, right? And as I've told earlier, that when it spreads, pterygopalatine, infratemporal, temporal, proptosis, cheek bulging, proptosis occurs, ophthalmoneurologic. The third, fourth, sixth, and the second cranial nerve can be affected. So these are the ophthalmoneurologic symptoms. Facial, in which there is cheek bulging, but if there is bilateral proptosis, it will be a frog face deformity. That is something you don't see in a lot of diseases. So this is a check point, right? Now, diagnosis. For diagnosis, you have to go for CT scan, the best investigation, right? MRI or carotid angiography. And always, whenever you are investigating this particular or performing a surgery, right, you should be keeping blood with you, because in any case, in any complication, it will bleed excessively, right? So you have to keep 2 to 3 units of blood or packed RBC along with you, and whenever you are ligating it or removing it via surgery, you have to do the embolization of the vessel to decrease the bleeding at the operation, right? And biopsy should be avoided, because as mentioned earlier, it is very sensitive and it can bleed easily. Treatment is surgery is the treatment of choice. Simple. Different approaches, you can read it. And chemotherapy, radiotherapy, and hormonal therapy is not now given, but earlier, before the era of tumor embolization, estrogens were used systemically to reduce the blood supply. Other benign tumors of the nasopharynx are the congenital tumors and the pleomorphic adenoma, chondroma, hamartoma, choristoma, and the paraganglionoma. Now, our second topic is the malignant tumor, in which there is the nasopharyngeal carcinoma. You have to remember that normally we do not do the geographic distribution, but here you have to remember that Chinese are very much prone to get this tumor, to get this cancer, right? So if in the scenario it's a person of China or Taiwan, you have to remember that, okay, this can go to this particular diagnosis, right? Etiology is genetic, right? The Chinese are having a higher susceptibility. The viral Epstein-Barr virus, that is an important MCQ point, that EBV is responsible for this particular carcinoma. And environmental, as you all know, that air pollution, smoking of tobacco, and other aspects can lead to this particular cancer. Now, the WHO classification is present classification is of 3 types: the type 1, 2, 3, keratinizing, non-keratinizing, differentiated, non-keratinizing, undifferentiated carcinoma. Pathology, it presents in 3 different forms. Either it is proliferative, ulcerative, or infiltrative, right? Now comes the important aspect, the origin, from where it is originating, the fossa of Rosen-Muller, right? So this is the site of origin. In case of the fibroma, the site of origin was the posterior aspect of the nasal cavity, right? Here it is the fossa of Rosen-Muller. This particular area, which is the nasopharynx, is richly supplied by the lymphatics. So any sort of carcinoma will lead to nodal metastasis, and cervical lymphadenopathy is a very telltale sign or leading sign towards this particular carcinoma, right? So if you see cervical lymphadenopathy, you should be conscious that, okay, some complication or something is happening, you should be conscious, right? And distant metastasis is towards the lung, bone, and liver. Now, clinical features. The previous fibroma which we studied, the nasopharyngeal fibroma, was from the 10th to 20th year of life, right? Second decade. But this carcinoma mostly occurs in the 5th to 7th decade, right? And it is also having the nasal symptoms. The nasal obstruction is a symptom, nasal discharge and epistaxis, and otologic symptoms, as you know, that it is fossa of Rosen-Muller. Fossa of Rosen-Muller is present near the eustachian tube opening, right? So if this carcinoma is present in the fossa of Rosen-Muller, enlargement will lead to the obstruction of eustachian tube, leading to separative otitis media, conductive hearing loss. Ophthalmoneurologic symptoms can lead to the squint, diplopia, cranial nerve 6, 3, 4 are affected. Second can also be affected. Trotted striate can occur. This diagram is something that you should be focusing and remembering and visualizing, right? So origin is the fossa of Rosen-Muller, right? From where it can obstruct the eustachian tube, leading to serous otitis media. It can go spread towards the nose and orbit, leading to nasal obstruction, epistaxis, proptosis. It can go into the cervical nodes, leading to cervical lymphadenopathy. It can distantly metastasize, leading to secondaries in the lung, liver, and bone. It can enter the foramen lacerum and ovale, leading to ophthalmic symptoms and facial pain. It can enter the parapharyngeal space. It can enter the retropharyngeal nodes, right? So this aspect is more important, and this is also important, but this is something that you should remember. Moving on to the cervical nodal metastasis, as I told you earlier that nasopharynx is highly supplied by the lymphatics. So any carcinoma will lead to the cervical lymphadenopathy, which can be the only manifestation of nasopharyngeal carcinoma. Distant metastasis already done. Now the presenting symptoms in order of frequency is at the top 90% cases, cervical lymphadenopathy is the presenting feature. Hearing loss due to eustachian tube obstruction, nasal obstruction, epistaxis, cranial nerve palsies, headache, earache, neck pain, weight loss. You have to remember these three symptoms especially. Moving on to the diagnosis, you do endoscopic evaluation, CT, MRI, X-ray of chest also, because testing for the secondaries for the lung, CT abdomen, secondaries, positron, PET scan, biopsy. Now in most of the cases, or in some cases, what happens is that you do a biopsy but you do not find anything. In that particular area, you are doing biopsy because, for example, you saw cervical lymphadenopathy and you are suspecting that this particular patient is having the nasopharyngeal carcinoma. But on biopsy, you are just there is no growth visible. So in that particular aspect, you do blind biopsies near the fossa of Rosen-Muller and the nasopharynx. And an audiogram is also taken to check the hearing effects. Now moving on to the treatment, the radiotherapy and the chemotherapy. Whenever a carcinoma is being discussed, radiotherapy and chemotherapy must be in mind. For stage 1 and 2, the radiotherapy alone is effective. But for stage 3 and 4, the radiation and chemotherapy must be done combined, right? For the treatment and of the recurrent disease, neck dissection is done, in which the removal of sternocleidomastoid is also done. That is a radical neck dissection, and mainly you do radiotherapy, chemotherapy. Otherwise, the radical neck dissection is also done in case of recurrent cases. Other malignant tumors of the nasopharynx are the lymphoma, rhabdomyosarcoma, plasmacytoma, malignant chondroma, adenoid cystic carcinoma, and melanoma. Hope you understand the concept of fibroma and the carcinoma. The fibroma is actually 10 to 20 years of age, and the carcinoma is 5th to 7th decade of life. The fibroma is originating from the posterior aspect of the nasal cavity, and the carcinoma is originating from the fossa of Rosen-Muller. Both are having similar signs and symptoms, but the thing that you have to remember is that recurrent epistaxis and proptosis and the cheek bulging, these are the telltale signs for the nasopharyngeal angiofibroma. And cervical lymphadenopathy, and only just cervical lymphadenopathy, is the telltale sign for the nasopharyngeal carcinoma. Treatment is different, and in this particular aspect, one more thing, for fibromas, nasopharyngeal angiofibroma, they are excessively sensitive. You do not have to do biopsy, otherwise they will bleed and person will bleed to death. So these are the things that you have to focus on, and history points, and then you will be going towards the diagnosis and treatment. Hope you understand these two topics.